Yeah, so this is sort of a new problem in myelofibrosis for us, where historically we have not had a lot of treatment options, but thankfully sort of that's changing for us now with sort of multiple JAK inhibitors available, another with Momelotinib likely to be available in the very near future for us. And so all effective agents and sort of do have some unique sort of populations in particular that I think we'll see them sort of being helpful in. Obviously, ruxolitinib has been sort of the standard of care for about a decade plus now and is still a great agent for sort of our standard kind of proliferative myelofibrosis patients, but does cause some challenges sometimes in patients who are more cytopenic, have anemia, lower platelet counts and things at baseline. And so some of our newer agents are really kind of fitting into that role now. So Pacritinib, which got approved about a year and a half ago now, a great agent in patients with a low platelet count in particular, specifically FDA approved for that group with a platelet count less than 50, who historically have been excluded from both ruxolitinib and fedratinib. So able to sort of expand to that population now, which has been really beneficial. And likewise do see anemia responses with that agent as well. So great option for some of our very cytopenic patients. Momelotinib, which hopefully we'll see get approved in the very near future here, potentially in the next week or so, is an agent that again has a lot of activity with the ability to improve anemia as well. So whereas ruxolitinib and fedratinib historically have caused worsening in anemia and sort of treatment-related anemia, see the sort of opposite with Momelotinib, with the potential to actually improve anemia. So for patients who are more anemic at baseline, especially those needing transfusions already, much better option for those patients to to not only help with sort of spleen and symptom improvements, which the JAK inhibitors have historically been used for, but also the ability to sort of improve anemia as well. So two great agents now for some of these more challenging cytopenic patients. Do have fedratinib as well, which does have data in the frontline setting and certainly can be an effective agent. Often use it more in the second line setting, sort of after ruxolitinib failure. It does have good data that's been a challenging group of patients after ruxolitinib failure. And so fedratinib does have good data with about 30% of patients who are resistant to ruxolitinib seeing spleen and symptom responses. And so that's generally where that agent, at least in my practice, tends to fit in a little bit more, is in that second line setting.